academic knowledge and community engagement, and leadership to promote mental health awareness and emotional resilience and holistic wellness. So that was a wonderful bio mentally. So you can continue with your session, and all the best.
Hello, everyone. I hope you are doing well. I am currently in Zimbabwe. I am from Botswana, but currently in Zimbabwe, and I am honored to be in the session and excited to be joining this platform with many other speakers who have such influential and excellent backgrounds. So today, my topic is on rural women in Zimbabwe and the mental health issues that we are facing currently. I'll also be speaking from my own work that I'm doing in the rural areas, and also going to be touching in on some of the challenges that I've seen and some of the experiences that I've personally encountered. So I'm going to share my PowerPoint slides. I'm just trying to switch them on.
Yeah, hi mentally.
Hello, can you see my screen?
Yes, now it's working. Thank you.
Okay, great. Okay. All right. So I am originally from Zimbabwe. I was born and raised in Zimbabwe. My husband passed away in April. So this is one of the biggest steps I'm taking moving forward from suffering from that loss. And he was well aware of this engagement. He was well aware and also pushing and encouraging me to be engaged with this conference. And so I know at the back of my heart, at the back of my mind, that he would be so proud of what I'm doing right now. So that is why I'm now relocated to Zimbabwe. So I'm going to be speaking also from my own personal experiences because I've just touched on loss, and so it means a lot for us here in Africa, for us here in Southern Africa, and just touching in about what it actually looks like when we are looking for mental health interventions. So these are the contents that I have, the points that I'll be speaking about today. I'll just get on to the first one, which is the challenges to mental health access in Africa. Okay, so in general, in Africa, there are so many misconceptions about mental health and what it looks like and how it's perceived. So, for example, in South Africa, you have people who are struggling with things like hallucinations. And with those hallucinations, it could be seen as an ancestral calling and seen as maybe the ancestors trying to communicate or trying to pass over a specific gift to the next person. So when someone experiences hallucinations, whether it's auditory or visual, or even some form of delusion, it is immediately given as if they are actually in touch with the other world, which is where they believe the ancestors are coming together to communicate messages. And of course, we know that in psychology terms, these can be seen as grandiose hallucinations or delusions, where one would believe that they have specific powers. And so this does obviously cause some form of misconception when it comes to diagnosis and care. And then, of course, we've got cases like here in Zimbabwe where kids who have ADHD are seen to be somewhat naughty or have too much energy, and it is concluded that this child is just a naughty child, and yet they're actually struggling from internal mental conditions that could be managed if they received the proper care. So I want to speak about rural women in particular, because I've just highlighted issues that are there in Africa, just with two countries. But I'm speaking in regards to the general society, but what more for our rural communities? So we've got traditional beliefs and practices. Like I'd mentioned with the South Africans, they believe that hallucinations are a form of ancestral calling. Also, there is this norm and way of viewing things, that certain behaviors, even someone who is, for example, wandering off, in confusion, whether they're an older person or young person, it's as if they're sort of being drawn by a particular spirit, and that needs to be taken care of spiritually through rituals, and it's misinterpreted sometimes as a traditional a ritual or traditional practice that needs to be taken care of, and nothing of the mental health is dealt with or even considered. Then, of course, we've got gender roles and expectations in Africa in general. I speak for whether it's the Southern or the Eastern or the Western or the Northern Africa region. Women are carrying out so many responsibilities and really just trying to keep the home intact. And when a woman is seen crying out for help, she is often advised by her elders that, you know what, you'll be fine, you'll be okay. This is how women do it. And of course, that causes not only mental conditions, but it also manifests in physical conditions, chronic illnesses, and can also compromise the wellness and also the longevity of that person's life. Um, we also have the stigma within the communities that is generally there across African nations, though there are some advances in certain nations. But in many of the African nations, especially particular to the rural communities, there is such a great stigma when you are seen, for example, having anxiety disorder, or having depressive disorder. You're often deemed as someone who is lazy or someone who can't get it together, or you are told to snap out of it or to find work to do. Maybe you're a bit bored. Maybe that's why you are feeling depressed. When somebody doesn't have the ability to wake up and just feel the need to bath and take care of themselves, and they're sleeping long hours and they have a low depressive mood and they're not able to eat, it's seen as something else, especially for women who are wives and mothers. So I'll just move on to the next slide. So this obviously does cause economic constraints on the services that are provided, because if the general population in the rural communities does not have respect for or need or see the appreciation of mental health as something that they should attend to in giving the services and the resources, then the healthcare services and also the resources that are supposed to be given towards that will be limited. So first of all, when we talk about rural communities in the African countries, there is a general priority towards healthcare workers. So your GPs and your nurses are the first. It's like a general basic. Any other specialties, whether into the dental field or whether into optometry or psychology, is a luxury, and that's how they view it in general. So there are limited resources, there's a limitation on accessing that mental health care. Even if you're, for example, you've given birth and you're suffering from postpartum depression, it's not considered as something that one would now spend money on, because already they're in the rural areas, they have limited money. And in fact, in the rural areas where I work in, the hospital there gives patients paracetamol for almost everything. Everything is paracetamol, paracetamol, paracetamol. So when it comes to mental health services, we are still a long way in talking about things like your antidepressants, because to them it's like a luxury. So there's also a big struggle in the fact that because they don't have the means of living and living well and living with the basic needs, things like insurance are not even a discussion in the African communities of rural areas. It's not even up for discussion. Even the urban areas, I mean, it's not a guarantee that every single person is on some form of health insurance. And even then, when you are on that health insurance, because we're still a long way in accepting mental health services in African countries, you find that the insurance companies are not yet covering psychiatric or mental health needs. And so you're able to go to a doctor and you end up not getting psychotherapy treatment, but you might end up getting medication and not actually having the side of counseling or psychotherapy, or more of an in-depth or long-term therapy. So there's also our last point there, that there is, because of the economic strains on rural women in general, they cannot put money together to be able to travel to hospitals. And where I work in Zimbabwe, in Gai Rural District, what we have seen is that there's actually very limited resources in terms of transportation. So they use donkey carts to go to hospital. So if somebody, for example, has spiraled into psychosis, they would be tied up and put on a donkey cart, because no one can carry them. There's no bicycle that can take them. I mean, you can imagine someone is in a maniac state of mind. The only way they would know how to deal with it best is to tie that person or to lock them up in a room until that person sort of calms down, and which is obviously not the right way of doing things. And now, when we're talking about other health services, these rural women, these rural villagers have to use donkey carts just to get to hospital. But there has been some development in some countries, like here in Zimbabwe, where if women are about to give birth, they go and camp at the hospital for about 2 weeks prior to their due date, just to avoid high mortality rates in losing their pregnancies. And that's something that has been implemented. But that is just in concern with the pregnant woman. In any other discipline or any other healthcare condition, you have to use your donkey cart or a bicycle if you're strong enough to be able to go to the hospital. But like I said before, when you get there, they'll probably just give you paracetamol anyway. So there is general stigma surrounding mental health illness, and I think we've touched on that. So I won't go into it too much, but what I have realized is that when a woman gives birth to a child who's, for example, autistic, there is this burden that she carries, that why is my child different from the others? And it ends up being that the child doesn't go to school at all, because at school, the child will be bullied and the teachers will not understand how to take care of that child. They'll just consider that child as as abnormal. And that is an issue that we are facing in the rural communities. There's a lack of education in that regard. There's a lack of exposure. There's a lack of knowing how to manage and how to assist even in educational services to take care of different intellectual disabilities such as autism and ADHD. So there's also misconceptions that we had mentioned about mental health and how they are viewed in the rural areas in general in the African continent. Sometimes mental health can be seen as a curse, or it can be seen as, what did you do wrong as a parent for you to give birth to a child who has a certain condition, or what has this young man done that he has now become schizophrenic? What has he done? What, maybe he borrowed money, maybe he didn't do some, he didn't do right by somebody. Maybe there's a reason why that person is now depressed, or why this person is now acting manic. So there's always some form of interpretation that are given and concluded. And sometimes these are carried for generations. There's also blame and shame, like what we're talking about within families, where it's just seen as, what did you do? How come, even that condemnation to say, my child has this condition, my child has Down syndrome, and the other children, or the other, my sister's children or my brother's children are born in a normal, and I put normal in quotation marks because, that's just a social perception. But they will think other children are normal, and therefore maybe there's something wrong with me. Maybe it's the way I took care of my pregnancy. Maybe the time when I was depressed, or the time when I was down, or the time when I was experiencing some issues. Maybe that's when something happened in my womb. And then of course there is that reluctancy to talk about mental health because it's not understood. So generally, when something is not understood, it's not appreciated. Okay, so I'll go on to my next slide. So there is limited awareness of resources, mental health resources, like we've mentioned, the education part of it. In hospitals, it's not there. You'll find that somebody is a nurse or a doctor in the rural area setting, and they don't even consider any of the DSM-5 diagnosis or any of the disorders, because to them it doesn't exist. And because they are probably brought up in that culture, they only look for things that are seen. And it's true, because mental health, sometimes we cannot put it into tangible, we cannot put it in a tangible form. But sometimes, because it's in the mind, it's not seen and it's not understood, so it can be easily misinterpreted. And so many of our medical practitioners are not really delving much into mental health, and sometimes all they know is depression or anxiety, and that's where they end. They cannot think of bipolar personality disorders. They cannot think of intellectual disorders, nothing of the sort. In fact, you might be shocked, but I was once in a conversation with a headmaster from the rural areas in the area that I'm working in Gai, and he just said to me in a very casual way, but you can imagine my shock when he said, the children in the rural areas that we're working with are just dull, which means they're not intelligent. And yet there are intellectual disabilities and even issues that have to do with the time when the mother has conceived the child that we should be looking and tracing at. But we're not looking at that. We're not asking ourselves what can be done. We're not even asking how women are taken care of from the time that they're carrying these children in the womb. But we're simply speaking ill. And that is the general behavior that you see in the rural areas. And that is why today I'm presenting a topic that is very much close to my heart, because I have seen how the misconceptions of people who are in the space of education or in the space of healthcare are seeing what should be taken seriously as something that they've done deliberately. Maybe you need to get it together and fix yourself. That is the mentality that is there. And in the rural areas, one thing that we must also realize is because it's rural and remote, it means sometimes even just having that access to phones and to information, it's not there. There's no internet, there's no Wi-Fi. In some areas, in the rural areas, there is no network to even just call a direct call. So there is no one you can call to ask, or a number that you see online that you can call to ask or to receive some form of care from where you are. It's just not there. It's not available. And of course, there's also very little training that is done on these healthcare providers, because they do not realize or recognize the urgency of speaking on healthcare matters with regards to mental health. So what are the consequences of limited support? So, of course, there is a rise in anxiety and depression amongst rural women. There is stigma around mental health. And there's also, of course, limited access to counseling, because who has time to be counseling people when they should be figuring it out? And everybody's got problems after all, and we're too many of us after all. That is the mentality that is there. And that type of mentality, or that type of perception, is going to cause a huge impact and a blow on the personal well-being of that woman, in how she presents herself, in how she, you know what I mean, how she presents herself, because she's not going to have to hide behind a smile. She's going to hide and say, okay, I'm fine, even though she's not well. But it's going to decrease her wellness. Is also going to spike up some of the symptoms, and eventually it's going to get to a point where she's not going to be able to contain the mental symptoms, because it's like a pressure cooker. And if that pressure cooker is not released and you just open that lid, it's going to blow up, and that's exactly what takes place. And some of these women end up spiraling into psychosis. So, what are the impacts on the family dynamics? They are strained relationships. Sometimes these women are seen as, oh, now she's becoming rude, or she no longer cares, or she's no longer connected emotionally. But it's because there's been a long existing mental health disorder that has been there underlying. And it does cause a strain on relationships, not just as husband and wife, but in general. Even if you're a young lady in your home and with your parents, and if they do not understand what you're going through, it can cause a strain, because they don't understand what's happening with you. You don't understand what's happening with yourself, because you're not aware, and that could cause a lot of friction in the home. There is the children's development that is affected. Definitely, if you are a parent and you've suffered from any mental health illness, like I'd mentioned about postpartum depression after a mother has given birth. There are many cases, especially at the hospital that I'm working in currently, where postpartum depression is only dealt with when psychosis starts to show up. So it could be that she is now hallucinating. She's not seeing things, she's hearing things, she's feeling things in her body, all kinds of hallucinations and delusions. Then that's when the family says, okay, now this is too much. And that's here in the urban areas. In the rural areas, you're treated differently when you have those symptoms. So you can just imagine what impact it has on the child, on the newborn child, how the mother takes care. Because even if you have postpartum depression, you still have to show up for your child. You are the mother after all. There's no mother who's given a time off to say, go and rest and take care of yourself mentally while we take care of your child. No, immediately once you've given birth, the child is your responsibility. Couples in general in the rural communities do not share responsibility. So none of this way, my wife is not well, let me just help her a little bit. No, I'm doing what I do. She needs to do what she does. She's the parent to the child. That is the mentality that we're also trying our best to address, because it has caused a lot of issues, especially with the wellness of these women. And of course, with the children being there as they grow up. If the mother is going through all kinds of stages, or even just circumstances that are happening in life in general, and she's not getting mental health care or counseling, it causes a lot of strain on how she communicates with the kids, and how the dynamics between her and the children changes. Um, there's also an issue of mental health illnesses. For example, if your child is born with autism, there is that burden that you feel as a parent, because you're not getting any help. No one in the community understands you. They've made you put you in a box where you have this great stigma, and nobody's there to help you, to assist you, to take care of that child. So there is that burden that you have as a caregiver, because now it's like your problem, and now you are the one who has to fix it. And then of course there's that breakdown of support systems, where in general you're not able to access any care that is within your limit, within your boundary in the rural areas. I'll move on to my next slide. So there is reduced economic productivity. Sorry, I've put that twice there. Please forgive me for that one. So if a woman is struggling from any mental health illness. For example, she's struggling from major depressive disorder. She's not able to work. There is no way that she'll be able to work, but she will be seen as somebody who is lazy. She will be seen as somebody who is just always sleeping or not really seen doing much. And meanwhile, there is a mental health condition in the background. There's also the issue of not of her not being able to come to work. For example, maybe there's a job in the rural areas where she is being asked to go and take care of someone's field to earn something from that. She will not be able to carry out all the operations every single day because there's going to be times where she's not going to be able to make it out of bed, and that is the reality. And of course, with limited mental health support, it restricts women's chances of career advancement and increase of growth. And this is something that needs to be dealt with because mental health is like physical health. If you are not well in your body, for example, you get into an accident and you crash in the accident and you come out, you're alive, but you've got bruises and scars. You don't just wake up and go to work the next day. You have to go to the hospital. Someone rushes you to the hospital. You are given wound treatment, you are taken care of, you are taken care of with pain management and all the likes. But with mental health services, it's like, oh, it's a luxury. Yet someone internally, mentally is bruised. And so it doesn't allow you to even think further into the next day because you do not have that will to live. You do not have that motivation to stand up and arise. So I'll get on to my next point. Okay, so there is a general higher rate in African rural communities of abuse. And I think that's something that we are all aware of because of the lack of exposure. And generally, that GBV is still existing, particularly in the rural areas. So what it does is that it because mental health illnesses are not being addressed, the perpetrators continue because no one is coming for them, and the women are more vulnerable, and that cycle of abuse keeps going on and on and on, and these women are suffering from all kinds of abuse and traumas that they're not being addressed and not being taken care of. So I'm going to go through the case studies in Africa. So in Africa, generally, like I've mentioned to you, there's no appreciation of mental health services. So you've got 150 million people in general that live with mental health conditions, but there's a great amount or higher number in that statistic that are not receiving care. But in Uganda, we've seen that rural women experience mental health challenges linked to poverty, gender-based violence, caregiver pressure, and limited access to professional help. In Zambia, the women that are from the rural communities experience depression and anxiety, and most of it has to do with that stress related to economic hardships and also social inequalities, like we've already spoken about. In Ghana, there is that lack of awareness. There is also financial challenges, and then there's just shortage of trained mental health providers. In Kenya, it's pretty much the same story. So you can see that there's a general limitation in all these African countries. But there is some success in some countries. So, for example, with Kenya, they do have community-led mental health initiatives that they've tried to implement, but this doesn't cover the whole community of rural women. So there's still limitations, but there is an effort that they have made. There's also the integration of mental health in primary care, which is a great innovation that they have put forward. And then now they've introduced the use of mobile technology, which has done great for the rural women that are starting to experience what it is to be able to use their phones, their mobile phones. But again, this doesn't cover the whole demographic of rural women. There are also interventions that have been done in South Africa. South Africa is much more advanced in healthcare systems in general. So there is the access to telepath options. So there's phones, there are numbers, toll-free numbers that one can use to call certain mental health services in the country that have been provided already. There are also policies that are also supporting women's mental health. These are great innovations, innovative measures that have been done in the recent years. And there's also more of that community healthcare training in the programs in the NGOs that are coming together to assist women in the rural communities. In Nigeria, there's also been the support from women's groups, which is great because that is what we need. There's also NGO support, and there's also an awareness that is spreading around cultural adaptivity, where we're trying to normalize conversations regarding mental health. There's also more training on the community leaders. These are your chiefs and your village heads, and people that are in places of influence. So, which is a great, great, great improvement. But this is also just in the recent years. In Zimbabwe, there is a huge population of women who are, or not women, but people in general that are living in the rural areas but are not able to access any mental health care services. And we can see there's a granny there that is sitting on a cot. That is the one that I was speaking about earlier on. She's on her way to the hospital. And being on the way to the hospital, she is going to be going at a very, very slow pace for about 10 to 15 kilometers, some even up to 30 kilometers if they have to go to another hospital on a donkey cart in the heat. You're already struggling with fever, or you're struggling with maybe you've got skin conditions or whatever it is, and you're on that donkey cart the whole way on a dust road in open air. It's the most uncomfortable way of being aided in any form of healthcare, let alone mental health illnesses. So there is a severe shortage in Zimbabwe of mental health professionals, which is why I am now back here in Zimbabwe. I'm working at the biggest mental health institution in Zimbabwe. And my aim is to make sure and ensure that the people in the community of Bulawayo, where I'm living, are getting enough mental health support, not just questioning if they've slept well or eaten well, but to really get into why they're feeling the way they're feeling, why those symptoms are persisting, and to make sure that there is that steady progress. So I'm going to get on to my next slide because of time. So there are initiatives for improvement. We've already discussed from other countries what they've done, and this is what generally should be done, where there is more mental health educational campaigns, where we're engaging with more of these community leaders, because they're the ones who are the first point of contact to defend and to talk about or to represent their communities. And also in our culture, we need to start to open up and talk about these mental health conditions that we are struggling with as people, let alone from rural or urban, but as people in general. So this is an intervention that I would love to introduce to you. It's called Khanya Be the Light. This is an organization that I've started. I started this organization in 2018. So this is the 8th year that it is running. And we have impacted over 200 young girls, and all coming from different backgrounds, but mainly from abused and neglected backgrounds. Some of them are orphans. And so this organization targets the mindset of a girl child. And we are looking at all the parts of her development. It's not enough to just give a young girl a box of sanitary pads and then say, okay, cheers, bye. But we need to make sure that she's motivated, empowered enough to stand on her own. And we've got some graduates that we have graduated from the program who are now working, earning, and are now educated, which is groundbreaking for the community where they come from. The community of Ngai is the poorest district in Zimbabwe. So for us to be doing this organization, it is such a joy and a privilege, though it has so many challenges that come with the work. But I have become a mother to over 200 young girls, and this has improved their lifestyles, improved how girls are viewed, improved even just their access to be able to call when there's problems that are surfacing. For example, we rescue some of the girls from abusive homes and we foster them into homes where they're able to be safe. We also then do psychotherapy and counseling with them. We take care of them, and we also take care of their other physiological needs, including going to school, which is important for a young girl. So these are some of the workshops that we have done. We have spoken about GBV, bullying. That is me in the center picture there, speaking on the brain, making them aware of the brain to be able to understand emotions and the hormones and why we act a certain way, especially as teenagers. So that is me there explaining it to them so that they could understand their bodies better, what is taking place in their bodies. And on the right side there, where they have books and they're cutting out things, those are their vision boards and journals, so that they're able to put to word what they're feeling and their aspirations and their goals. So we really try our best to motivate them to be the best that they can be. But what I would love to say about these young girls, generally, there is a pandemic of teenage pregnancies. It's so overwhelming that although we do have so many interventions that we put, we make sure that we work with the girls step by step on a mentorship basis, on an accountability basis, even to the point where we ask them, are you seeing anybody? Okay, are you now sexually active? Okay, what is happening, in your relationship with your parents? So that we are bridging that gap. There is a general gap between them and their parents and their school and generally the community, and that makes them feel like they can figure life out by themselves. But by so doing, it has increased the number of rate of teenage pregnancies. So the girls that have graduated from the program are actually the first in the entire village to be educated and to do well. So we've got two main service pillars that we have provided for mental health services. So, like I've mentioned already, I won't go through it again. We have provided abused survivors psychological rehabilitation programs, and we've also presented to them opportunities for leadership training. When you meet these girls, because of their background, they will not be able to look at you in the eye or even speak the way I'm speaking. They will look down, muffle their words, and they feel very insecure because culturally they're taught that girls don't have much in community, they don't have much in society, they don't have much value, they don't have a voice. So we are actually undoing that narrative, and by so doing, we've got a young girl there in the picture that has graduated. That is her and her mother, and she is now a dental assistant in a dental surgery. And last month she was actually able to, from her earnings, to buy her family a toilet. That is how much backwards we are, that for her it was such a priority for her to make sure that her family has a toilet because they were using the bush. And so when I mean rural, I really mean rural. I really mean this is the most remote side of town. Most of them have never come into town. Most of them have never seen cars or traffic lights or a bank or a mall or any of that. So when we go out there, we really try to bring more exposure to them by enlightening their minds. Okay, so we've also got psychosocial interventions that you can see there. We have projects that we call Vukuzenzele Initiative, which means get up and do it yourself. And by so doing, we're allowing women to be more independent. If you can see the picture to the left with the plates, we are encouraging women to get into arts. So those are their paintings and their drawings, using enamel cups and plates. And then in the center, we've got baskets that are woven by using grass and trees. So these are just natural resources that they're using for beautiful crafts that are used worldwide, that we sometimes ship out to different countries for customers. And then on our right, that's a model of ours here at Kanya. She was modeling the girls' work. Those are beaded jewelry that she has made. This is a typical traditional bridal look, and our girls are now able to make this from head to toe. So we're so excited because this is also a way and a means of making money. We want to also scale up our projects, and this is where we would love to ask for your assistance. Those who are listening to us, or listening to me rather today, we would love to get into a deeper level of basket weaving by partnering with countries such as Kenya and Malawi to involve trainers to come here and teach more of our community how to do diverse patterns that we know are going to be more marketable to the world and our customers out there. And we also want to scale up painting so that we are painting more of the canvases and more of the detailed and complex images. But because of lack of funding, we're not able to really get the adequate training. Sometimes the training can only last for a week and then the girls have to practice on their own. But when we get into a proper training program, it costs up to $2,800 for the girls to be able to attend this program, and that is for 50 girls. So you can imagine 50 young girls whose lives will be impacted forever in the area of crafts, arts and crafts. And then on the right side, we've got bags and belts that we want to get into. This is also another, it's a higher level, it's a higher level that we know we are not there yet, but we want to scale up. And so we're also reaching out to the listeners, those who are able to assist us and support us in any way. Our budget for that is also 3,500 for the training. That will be trained by somebody or trainers that are coming from South Africa. So they will not be coming from locally because such bidding is done in South Africa. But this will also give the young girls an advantage, and we will also be able to sell more and more of our work to more customers, and they'll be able to live better. When we tackle the socio-economic side of things, a lot of these mental health conditions and a lot of the stressors are reduced. So when a young girl is able to be independent and not leaning on a man or a marriage to get some form of funding or finances, she's able to take care of herself better, and she's not rushing into marriage. Right now our girls are getting married at 18, 19 years old because of these economic challenges that they're finding. And of course at that age you end up being vulnerable to all kinds of abuse. So, what is the future? This is my last point. What is the future for mental health in the rural areas? So, of course, we need to be more culturally sensitive. We need more maternal mental health services that are given to rural women. We need to address gender inequalities. We need to also be addressing the violence and the traumas that are taking place against women because they are already in a marginalized background. And so this is something that we need to do in the future for all African countries, for women living in the rural areas. And lastly, we need your support as Khanya Be the Light. It's one area that we are so passionate about, but we need your support to be able to take care of these young girls. And today, if you're listening to me and you are in a position to help us, please do get in touch. I will put my email in the chat box, but please do get in touch with us and our team so that we're able to do more work. But thank you so much for your time, and thank you so much for listening.
Yeah, yeah, Mentle. So that was a wonderful session. So we have learned a lot more about Zimbabwe and the current situation that you are facing and the future solutions. Yeah, so please drop your email in the chat box. So our audience will be connecting with you and we can
Thank you
discuss
so
with them.
much.
And there are a lot of questions in the chat box. So as the time is up, we will be sharing all the questions to your email. So you
Okay.
please go through that and answer that. And thanks
Yes.
for your presence again. And have a wonderful day. Thank you.
Thank you so much. Really appreciate it.
Yeah. Namaste. Bye bye.
Thank you.
So please join backstage and enjoy the next session. Okay.
Thank you.
Yeah. Thank you. Bye.
Bye.